Once again, welcome to Medicomello. Today we are going to discuss the topic cardiac cycle and Jvp. So, coming to our topic, cardiac cycle. The cardiac cycle is of 0.8 seconds duration. It consists of both atrial systole and ventricular systole, and followed by atrial diastole with ventricular diastole. In the atrial systole, it lasts for around 0.1 seconds and the diastole is around 0.7 seconds. In the ventricles, the systole is around 0.3 seconds and the diastole prolongs for about 0.5 seconds, so that the total is 0.8 seconds. That is the duration of this cardiac cycle. Next is what happens during this cardiac cycle. What are the steps of the cardiac cycle? First of all, the atria is filled with the blood, as well as some blood is still seen in the ventricles. So once this atria is filled with the blood and the SA node is stimulated, both the atria contracts, and that is known as the atrial systole. So the entire blood comes down into the ventricles, and this is the first stage of atrial contraction. The next stage is, as this atrial systole ends, the ventricle get all the blood, and after that the atria tries to dilate. That is, atria tries to relax back after its work. This stage, the ventricle has got some tendency to contract, and that is known as this isovolumetric contraction. Towards this end of the stage, the mitral as well as the tricuspid valves will shut close, as the next stage is the ventricular systole. So before the ventricular systole begins, then both the mitral and the tricuspid valves close, so that they prevent the backflow of the blood from the ventricles to the atria. Mitral as well as the tricuspid valves close. Towards the end of the isovolumetric contraction stage, there causes the S1 heart sound. This is just before the ventricular systole. Next stage is the ventricular systole, where the ventricles contract and there is ventricular ejection. That is, all the blood pumped out of the heart via the aortic as well as the pulmonary artery. Next stage is ventricular diastole. After the contraction of the ventricles sit back and relax. But we have to prevent the backflow of the blood from the aorta and the pulmonary artery. So the aortic and the pulmonary valves must be shut closed during this ventricular diastole. And here the mitral as well as the tricuspid valves are still kept closed, so no blood is seen in the ventricles. So this is the early ventricular diastole, and it is known as this isovolumetric relaxation, where the ventricles are empty. Next stage is the late ventricular diastole. Here there is passive filling of the ventricles. It is due to the opening of the mitral as well as the tricuspid valve. Along with this passive ventricular filling, both the atria are still receiving the blood. So once the blood levels in the atria rises and touches the SA node in the right atrium, it produces the stimulus and occurs the next atrial systole, and this forms a cycle known as the cardiac cycle. Here these are the stages of this cardiac cycle. First is the atrial contraction. Next is isovolumetric contraction, where there is closure of M valve along with the T valve, and this causes the S1 sound. But here the semilunar valves are not yet opened. Next is rapid ventricular ejection. That is the semilunar valves open, that is aortic as well as the pulmonary valves. Now only the blood is flowing out, and that even rapidly. So next is the slow ventricular ejection. Why it is the slow? As a lot as a large amount of the blood has flowed out of the heart in the rapid ventricular ejection, the intraventricular pressure has decreased, and due to this lesser gradient, lesser pressure, there is only less force in the heart to pump the blood out, so the blood goes out only slowly. Next is the isovolumetric relaxation, that is, the ventricles relax, and this stage begins with the closure of the semilunar valves, that is the A and the P valves, producing the sound S2. Here no blood comes into the ventricles. Next is the stage of the passive venous filling, and that has got two sub-stages, that is rapid passive ventricular filling and slow passive ventricular filling. This is the cycle of heart. Regarding the heart sounds, we have seen that the atrial contracts, next second stage the atrial relaxes, and there comes the ventricles. They have the tendency to contract, but there is no change in volume yet, and this is the isovolumetric contraction. So just before the ventricle contraction, the mitral as well as the tricuspid valve closure, producing the sound S1. This is just before the ventricular systole, and it is to prevent the backflow of the blood to the atria, and that produces the S1 sound. Next stage being the ventricular systole, and here both the aortic valve and the pulmonary valve are open. During this stage, all the blood are flowing out of the heart along this aorta and the pulmonary artery, and after that, while the ventricle tries to relax, that is in the ventricular diastole, we have to prevent the backflow of the blood from the aorta and the pulmonary artery, so there occurs the closure of this aortic and the pulmonary valves, producing the sound S2. As here the mitral as well as the tricuspid valves are closed, the blood is still in the right atrium and the ventricles are still empty. Next stage, while the pulmonary as well as the aortic valves are still closed, the mitral as well as the tricuspid valves are open, so there is passive ventricular filling, and again occurs the atrial systole once the atria is filled with blood. This is how the S1 and the S2 are being produced. Next is about Jvp, that is jugular venous pressure. What is Jvp? It's a pulsation that we are seeing in the neck. These are fluctuations in the right atrial pressure, that is in the cardiac cycle, and it generates pulse which is transmitted into the jugular veins backwards. It is observed at an inclination of 45 degrees, and that in the internal jugular vein. Let's see how the Jvp wave is produced. First of all, this is the line diagram of the heart. This is the right atrium, this is the left atrium, this is the right ventricle, and this is the left ventricle. Here initially the right atrium contracts. Due to the right atrium contraction, there is increased pressure in the right atrium as well as in the superior vena cava and in the internal jugular vein. So this increased pressure causes this A wave, and thus the A wave is produced corresponding to the right atrial contraction. Next is the right ventricular contraction. Due to the right ventricular contraction, there is increased pressure in the right ventricle. Due to the bulging of the tricuspid valve into the right atrium, there is increased pressure in the right atrium, and that is reflected in the Jvp, and this right ventricle contraction produces the C wave, and this is due to the bulging of the tricuspid valve. Next is the right ventricular relaxation. So what happens? The bulged tricuspid valve, it goes down due to decreased pressure in the right ventricle, and this causes the decreased pressure in the right atrium, and that causes the X descent in the Jvp. So X descent is due to right ventricular relaxation followed by tricuspid valve moving down. Next, there is passive filling in the right atrium. So as the blood is passively filling the right atrium, there is increased pressure in the right atrium, and that causes V wave in the Jvp. And lastly, there is atrial emptying due to the opening of the tricuspid valve. So due to flow of the blood from the right atrium to the right ventricle, and as the right atrium gets emptied, there is reduced pressure in the right atrium, producing the dip in the Jvp. That is the Y wave. So the Y wave is produced by the atrial emptying, and thus we get this form of the wave in Jvp, whereas the A wave is caused by the right atrial contraction, C wave is caused by the tricuspid ascending on right atrial contraction, and X descent was due to the tricuspid valve descending during the right ventricular relaxation, and the V wave, which is due to passive venous filling in the right atrium during the right atrial diastole, and the Y descent, which is due to the tricuspid valve opening with atrial emptying, and this is the Jvp wave. This is the Jvp represented with ECG, and here we can see the atrial systole and the isovolumetric contraction, ventricular ejection phase, and the isovolumetric relaxation phase, and the ventricular filling phase. So in the atrial systole occurs the A wave in the Jvp, and followed by the dip in the isovolumetric contraction, and just after that in the ventricular ejection there is the C wave, and towards the end in the ventricular relaxation the X descent, and in the isovolumetric relaxation phase due to the passive venous filling the V wave, and in the ventricular filling due to the opening of this tricuspid valve and right atrial emptying, there is the Y descent. And here we can see the P wave, the QRS complex, and the T wave in the ECG. P wave, which is the message for the atrial contraction, can be seen just before this A wave, and it causes the atrial systole and produces this A wave in the Jvp. And just before the ventricular ejection there is QRS complex, and after that there is ventricular ejection, and there occurs the C wave. And towards the end of this ventricular ejection there is the decreased pressure in the right atrium causing the X descent, and just after that there is the T wave, which is the message for the dilatation of the ventricles, and that ends this ECG. So here in the isovolumetric contraction, just before the ventricular ejection, there occurs the closure of this mitral as well as the tricuspid valves, and that produces this S1 sound. That is towards the end of this isovolumetric contraction just before the ventricular ejection. And towards this end of the ventricular ejection, just before this isovolumetric relaxation, the A valve and the P valves close, and thus they produce this S2 heart sound, and this is just before the ventricular dilatation, that is at the beginning of this isovolumetric relaxation phase. We have to know that during inspiration there is decreased pressure in the chest, and as a result the jugular venous pressure falls down. But in case of the constrictive pericarditis and sometimes in cardiac tamponade, there occurs a restriction in the cardiac expansion. So the heart has got reduced dilatation, so it cannot accommodate much amount of this venous return. So during inspiration, where there is increased venous return, the heart cannot accommodate in constrictive pericarditis and cardiac tamponade, and that causes increased Jvp, which is a paradoxical situation. And this paradoxical increased Jvp is known as the Kussmaul's sign. Next is some other pathological conditions of Jvp. Prominent A wave in the Jvp. Why there is prominent A wave? A wave is seen corresponding to the right atrial contraction. So what happens? So in case of pulmonary hypertension, there is resistance in the flow of the blood downwards. So as a result, there is increased pressure backwards, and this causes increased right atrial pressure, and thus there is prominent A wave. In case of tricuspid stenosis, that is restriction of the blood flow from the right atrium to the right ventricle, So during the right atrial contraction, due to the stenosis here in this valve, the right atrial pressure increases and causes a prominent A wave. This is similar to the pulmonary stenosis, where in severe pulmonary stenosis there is reduced blood flow away from this right-sided chambers, and as a result the right atrial pressure also increases and causes the prominent A wave in the Jvp. And what about the absent A wave? It is seen in the atrial fibrillation, where the atria fails to contract properly. There is no pucca atrial contraction as there is atrial fibrillation, and there we are unable to see an A wave. Next is prominent V wave. It is seen in tricuspid regurgitation. V wave, it is due to passive filling of this right atrium. So if there is tricuspid regurgitation, there is backflow of the blood to the right atrium, and it causes increased pressure in the right atrium as there is regurgitated blood from the right ventricle and as well as the blood filling into the right atrium, and this causes a prominent V wave. What about the cannon waves, that is cannon A wave? They are huge pathological A waves. It is seen when the right atrium contracts against a closed tricuspid valve. That is, the right atrium expects the tricuspid valve to open during its contraction so that the blood flows out of the right atrium to the ventricle. So when this tricuspid valve fails to open during the right atrial contraction, the pressure again builds up in this right atrium, and that causes the huge A wave known as the cannon A waves. It can be of regular type and irregular type. Regular type is seen in nodal tachycardia, and irregular type is seen in complete heart block in classical AV dissociation with ventricular tachycardia. That is, in complete heart block, the right atrium contracts, but there is the failure of communication to the right ventricle. So the tricuspid valve fails to open. This is the same in classical atrioventricular dissociation. And next, some points regarding the murmurs. Murmur occurs due to abnormal flow via a normal valve or a normal flow via an abnormal valve. So we have seen that there are 4 valves. 2 are semilunar valves and 2 are atrioventricular valves. So semilunar valves are aortic valves and the pulmonary valves. In the aortic valve and the pulmonary valve, during systole, if there is stenosis, then there is reduced blood flow away from the ventricles. So during systole, if there is stenosis, we can hear the murmur. But what about the regurgitation? During systole, the regurgitation has got no role. Even if there is regurgitation, we cannot hear, we cannot identify this regurgitation during the systole. So in aortic or pulmonary stenosis, it causes this systolic murmur. Just opposite to this is the regurgitation. We have seen that during systole, if there is regurgitation, it is not at all evident. But during diastole, if there is regurgitation, then there is backflow of the blood into the ventricles, and that causes the murmur. So if there is regurgitation, then it is seen only in the diastole. So in aortic and the pulmonary regurgitation, we can hear the diastolic murmur. That is, the regurgitation is seen only in the diastole. Just opposite to these semilunar valves, the mitral and tricuspid valves act. So in systole, what happens? There is the blood flowing out of those ventricles via the aortic and the pulmonary valves, and there is tendency of the blood to go to the left atrium and to the right atrium. So if there is any stenosis here in this mitral as well as the tricuspid valve, it is not acting in the systole. we cannot identify the stenosis during the systole, but there is role for regurgitation. That is, in systole, if there is regurgitation, then the blood flows from the ventricles to the atrium, and there we can hear the murmur. So the regurgitation of the tricuspid and the mitral valve can be heard at systole as the systolic murmur. Whereas if there is stenosis, then it is seen only in diastole. In diastole, there is relaxation of this ventricles. Ventricles receive the blood from the atria. But as there is stenosis, the blood is not properly flowing via this mitral and the tricuspid valve. So due to that turbulence, due to the stenosis, we can hear the murmur in the diastole only. So the mitral and the tricuspid stenosis is evident only in the diastole as the diastolic murmur. Thus we are able to remember the murmurs in different kinds of pathological valves. So keep in mind, aortic and the pulmonary stenosis causes systolic murmur, whereas the mitral and the tricuspid stenosis causes the diastolic murmur. And here in the mitral and the tricuspid, regurgitation causes systolic murmur, whereas the aortic and the pulmonary regurgitation causes the diastolic murmur. And this is all about the cardiac cycle and the Jvp, and thus it's an end of our topic. Keep in mind, the pain you feel today will be the strength you feel tomorrow. Keep going, pray well, and let's wait for a good tomorrow. And thank you for watching this video. This is Medico Mellu. Please like, share and subscribe.